Hi, everyone. Thank you so much for the invitation. It's truly an honor to be here. It's my first time in the conference. It's amazing. So thank you very much. So I'm an adult endocrinologist, and I have experience with male staff. I have to do my own homework for the female staff. But Prof. Davis as well, she will complement my talk later. So I'll start with male survivors. Perfect. So on the left-hand side, you can see the spermatogenesis, where is the process where the immature cells go under a lot of changes, and that's a continuing process happening in men. In the histopathological slides that you can see in the middle, where the factories are, the seminiferous tubules, to produce what is the sperm, which is the little cells we can see there on the side with the tail. And the whole process is a continuing process that's happening throughout the life, every 72 days. And is governed by the HPG axis, so hypothalamus, where the GnRH is produced, that stimulates FSH, LH in the pituitary. And please remember FSH, LH for the future talk. That then stimulates Sertoli cells, which are cells that help with the sperm to be protected by any abnormal stimuli, and the testosterone, which is important in the spermatogenesis process, and that is the testosterone that the testes produced. So what's happening in the situation where the hypothalamus on the pituitary is not working? The easiest and probably the well-standardized treatment throughout the country is replace the end organ, which is the testosterone. And Embido is one of the pharmaceutical agents we use. It's an intramuscular injection every 10 to 12 weeks. However, exogenous testosterone suppresses spermatogenesis. So what we do then when men are seeking fertility, but they are on Embido? So we swap the treatment for gonadotropin therapy, and this is the LH-FSH that the hormones produce from the pituitary gland. And I would like here to present the case of one of my patients that I met when I was doing research with my research supervisor, Jana Jayasina. So he was a 30-year-old gentleman that we saw him in our service because he was seeking fertility, and he was referred from another center, so he was not under our endocrine care. He had a history of craniopharyngioma, which was diagnosed, and he was operated when he was 9 years of age. And when I met him, he was on a thyroid, steroid, testosterone, and antidiuretic hormone replacement. So he has been advised to stop the Embido injections. We've done some baseline investigations, and you can see that the LH and FSH were low, as well as the testosterone, in keeping with the secondary hypogonadism, so a pituitary problem, and the rest of the hormones were replaced and within normal limits. He was examined clinically, and he was found to have a low testicular volume, less than 4 millimeters is before puberty, and he also had a semen analysis to identify his baseline semen parameters, but there was no sperm seen, and the volume was just below 1 mil, which was on the low side. So we started him treatment with Gonasi, which is the LH equivalent, and Menopur, which contains actually both FSH and LH, but is the FSH equivalent, and we decided to start with both hormones at the same time because he had prepubertal onset of the condition. And you can see here on the first column, I have put the reference range as per the WHO, so the World Health Organization reference of what's happened to him over a period of 3 years. And you can see the first 6 months of treatment, there was no sperm, the volume was getting a bit better. October 2023, which is the 12-month cutoff after he started the treatment, he just had started seeing some motile and immotile sperm seen. And I was very happy and glad to see that 3 years down the line, his sperm concentration was almost reaching normal values, and the rest of the parameters within normal range. So here a little bit of our meta-analysis that was done in 2014 and has informed clinical decision and management. And that's the data that quote when we see these patients. And this is touching to some of the discussions we had before about testosterone replacement therapy, whether it has an effect or not. So what I'd like to point out here is that overall, the chances of developing sperm with that treatment in this cohort of patients who have secondary hypogonadism is 75%. If there has been only prepubertal onset, the chances are lower. There is no effect of what type of FSH, whether this is the recombinant form or this is a urinary purified FSH. The combination therapy, we think because there was a mixed population of prepubertal and pubertal, was actually doing better. And the previous use of testosterone did not have an effect. And this the same meta-analysis look at the mean sperm concentration. And overall, with the gonadotropin therapy, LH and FSH, it was about 6 millions per ml, so well below the cutoff. Again, what it shows here is that if there was only prepubertal onset of the hypogonadism, they have less sperm compared if they had postpubertal and a mixture of population. The combination therapy resulted in a higher sperm concentration of about 12 compared to HCG therapy only. And again, testosterone treatment had no effect on the final sperm concentration. And this is another study, which was a retrospective study over a period of 30 years, where they included 75 men. And what I want to highlight here is that the mean concentration during pregnancy was 8 millions per ml. And then here we can see they just starting the treatment and monitor the men over a period of time. And then here we can see the percentage of men who had any sperm in the ejaculate during the treatment, people who had over 5 millions per ml, men who achieved to impregnate the women. And then here is the 20 million. That was the normal reference range as per WHO back then. So what counseling should doctors give men on sperm inductions? So we normally say that the chances and the timelines. So these are lengthy treatments. You not start and then after a few months you would expect to have a sperm. It takes minimum 2 years for our patients. We give advice that it will be important that the female counterpart is also been investigated, because up to 50% of the time, the issue may be lying with both. And there are some factors that needs to be taken into account for IVF, such as the GP normally to investigate and refer the age and BMI of the partner and whether they will be eligible. And I will talk later about the IVF. So we normally advise about a partner being screened as well for subfertility. And the moment they see any sperm on the ejaculate, we advise for regular intercourse. And there is no need to time the intercourse to the menstrual cycle. So overall, the factors that influence positively is if men had normal sexual development, and that means that the testes were developed properly and went down to the sac. They didn't have any delayed puberty, and they had higher testicular volume and use of FSH from the beginning. Whilst factors that had no effect was previous use of testosterone replacement therapy, and I was sorry to hear your experience about that the gonadotropins are not going to work, and the type of FSH as well, so whether this is the recombinant or the urinary. And remember, I always consult my patients in the end that we try with a medical therapy, but if that fails, then we have the toolkit of assisted reproductive technology such as IVF or ICSI, and we can also refer our men for surgical intervention for what it's called TISI, which is testicular extraction. So the urologists, the surgeons, cut the testes in half and try to find sperm inside. Moving on now to the female survivors. So on the contrary, compared to what I described about men, where the spermatogenesis or the generation of the sperm is a continuing process, women are born with all the eggs from the beginning. However, the important thing is the follicle's development. And this is how I have it in my mind, is this little protective case where encompasses the egg that needs to become developed from a premature state to a more mature. And that's the releasing of all the hormones of estrogen and progesterone from the ovary from this follicle. And again, this is under the regulation of hypothalamus and pituitary, the same pathway as I described before. So what happens when the hypothalamus and pituitary is not working? We replace the end hormones, estrogen and progesterone, and that could be in the form of a tablet or transdermally, either with a patch or with a gel. So the approach is then for female survivors is to try and stimulate the ovaries to produce the follicles and to release the egg. We can do this with ovulation induction by using FSH and HCG as a trigger, or the human menopausal gonadotropin, which has both FSH and LH, and an HCG, which is the LH trigger for the ovulation. This is done in fertility clinics led by gynecologists, and it's important that these women have observed ovarian response with a transvaginal ultrasound to assess the progress of the follicles as they develop, as well as serum estradiol monitoring. So this is a blood test, because as the follicles progress and develop, the more estrogens they produce. And then in the end, they can be used either in assisted reproductive technologies or with a timed intercourse. It's important that a basic infertility workup is also performed, such as hysterosalpingography and transvaginal ultrasound for androgen follicle count and uterine morphology assessment as well, to rule out any other issues rather than the anovulation. So here, this is where I did my homework about the female stuff. So it was a systematic analysis published in 2019, where they looked at evidence of women with hypopituitarism due to pituitary and hypothalamic disease, and they quote that the fertility range is between 47 and 76% following assisted reproductive technologies. To give some context, that was informed by approximately 6, most of them was retrospective studies, so not the greatest quality. One of them, it was the second point I have here, which was a prospective 2017 observation study of outcomes that only had 5 women, but they reported 100% success rate. And that was either with a timed intercourse or insemination or IVF. And what is important to know is that women with onset of hypopituitarism during childhood may have morphological disturbances of reproductive organs. So what we said before, so the ovaries and the uterus might be smaller, and that may have effect in carrying a pregnancy. And conception in patients with childhood onset hypopituitarism, so prepubertal, may not only be impaired by the loss of the gonadotropins, but also by disturbances at the ovarian level as well. So the poor fertility outcomes, and if we compare women who had panhypopituitarism versus women who only had isolated hypogonadotrophic hypogonadism, are worse, and is worse if they had childhood onset. And we believe this is because of the change that's happening during puberty in a female body in the fetoplacental and ovarian function. Improved outcomes, I would say adult onset, good optimization of the other hormone replacement therapies, and being cared in a multidisciplinary setting. So, challenges. Even though NICE guidelines recommend offering 3 full cycles to eligible women under the age of 40, there is a lot of disparity. So, not only because of ethnicity, socioeconomic status, family type, but as well as where you live or where your GP is registered at. Particularly for men, the main challenges are they have to be referred to a specialist care setting. Not all hospitals can give gonadotropin therapy, and a lot of times patients need to travel far. So where I work currently, I had patients from Brighton or from the northern part of the country. There have been shortages with some of the medications. So Gonasi, I remember, I was waking up with the stress where I'm going to find this medication so my patients don't miss any treatment. And particularly for women, I would say it's the IVF funding thing, which it's a postcode lottery, as he has mentioned already. Really depends on commissioning policies, age, BMI, how many cycles, whether you had children before, whether your partner had children. And here is a map of England, of how the money is distributed. So essentially we have 42 integrated care systems in England, and each of them is responsible for how they distribute their money in the care. And there is a lot of disparity. So Lincolnshire, just for example, only offers one NHS funded cycle, whilst for Cheshire and Merseyside at the moment is under review, but they're probably going to a single cycle, versus North East and North Cumbria offers 3 at the moment. And that was a very nice timeline I found online showing the IVF milestones. So the first IVF baby was born in Oldham in July 1978. Then in 2004, NICE guidelines. So NICE guidelines are the national guidelines that essentially informed clinical decision making in the UK. Recommended 3 fully funded IVF cycles, and the health secretary then committed to offering 1 full cycle. However, they did not provide what sorts of a timeline the NICE guidelines will be able to be implemented. In 2009, the World Health Organization recognized infertility as a disease, so failure to achieve a clinical pregnancy after 12 months of more of regular unprotected sexual intercourse. NICE guidelines, again, updated in 2013. They continue to recommend 3 fully funded IVF cycles. I was happily surprised to see that in 2016-2017, in Scotland, people were given access to care, which was fully compliant with the NICE guidelines, and in addition provided access to treatment to people with the same-sex relationship without the need to demonstrate subfertility. Further later on, in 2017, again NICE fertility guidelines updated, suggesting again, recommending the same as before. And in 2019, a benchmark price for IVF was published by NHS England to help guide how much commissioners are spending on IVF in the treatment area, as well as the Human Fertilization and Embryology Authority issued guidance to promote a more consistent and better quality commissioning decision across the UK. In 2025, we have the draft of the new NICE fertility update. And I'll be closing with a case business that I found supported by the British Fertility Society, try to tackle the IVF inequality.